The exam is exclusively, again, for the most part, with the exception of some of the special tests, is done entirely from the right side of the person. The patient is supine. So again, after you've made that determination that they don't have to void their bowel or bladders, you know, everything, they're relatively comfortable, you can then have them get to the supine position. We really don't, beautiful. You're gonna have them put a pillow underneath their legs, okay? Just like that. You know, again, these aren't the best, but you know what? It works. And what this does is, especially if somebody has a lower back problem, you really want to be conscientious of the legs. So again, I really suggest getting some of those kind of round bolster pillows in your practice, because like I said, anytime you're doing some type of a lower back complaint, it's not a bad idea to, you know, examine the abdomen, because there are a lot of visceral structures that can give off abdominal pain. The ultimate one being the AAA, which is something you definitely do not want to miss. I've already had 2 in practice. They weren't ruptured, obviously, but they were in the process of becoming larger. So it is definitely something you want to take very special care and special consideration of. All right, excuse me. So obviously the first part, and the biggest thing I want to say is there's 4 quadrants. Have you guys learned about the 4 quadrants already? Yeah.
Nope, never learned.
One of the things I'm sure that you learned is the lower quadrants are a lot lower than you think, okay? A lot of folks, you know, exactly. So he pulls down the pant line about an inch or 2 and that's it. All right, have the patient pull the pant line. You don't pull the pant line, again, you want to have the patient feel in control. But really the lower quadrant is exactly just, you know, literally it's in the suprapubic area. You know, especially if there's a bladder condition or whatnot, sometimes there's suprapubic tenderness. So you really want to make sure that you are accessing the entire part of the abdomen. The first thing we're going to do is inspect. And again, the patient, as you can see here, is in the supine position. Really, the first things you're looking for are very similar to your spinal exam. Looking for any areas of discoloration, scars, any visible bruising, any abnormalities, discolorations, abnormal pulsations. Now, you will see some abdominal pulsations in the abdominal aorta in the epigastric region. That's normal, okay? What you don't want to see is abnormal pulsations that are relatively widened. All right, again, that could give off evidence that there's a potential aneurysm. All right. Now, one of the things too in your notes, Dr. Sherman always, you know, points out, you want to look for the presence of stretch marks and striae. Striae is from Cushing's disease. You learned about Cushing's disease, I'm sure. All right. Striae are going to kind of give off this purple, you know, these purple marks. It's going to have this purplish consistency, but stretch marks are going to be generally white. Why do we care about stretch marks? You know, we say them that they're there, but ultimately, what is really the concern of stretch marks? Why are they there, first of all? What happens?
Rapid weight gain.
What's that?
Rapid weight gain.
Certainly could be rapid weight gain, exactly, or anything that increases the increases the elasticity of the muscle, right? So if folks all of a sudden got into a you know, a heavy weightlifting regimen, the biggest problem is it's scar tissue. Remember, if the intra-abdominal wall is, you know, filled with fibrotic adhesions, that's going to cause some dyskinesias. That can cause pain. What we're finding is poor fascial movement, poor muscular dyskinesias is a source of chronic pain. So it's definitely something that if you see it, oh, okay. Well, no, you want to then go ahead and we'll teach you over the next couple of semesters about functional pattern movement assessments and whatnot. Is the patient contracting their abdomen appropriately? Is their abdomen working the way it should be in terms of stabilizing the spine? So depending on how many stretch marks and the size of the stretch marks, yeah, that could be definitely a functional indicator that this person may have abdominal dyskinesia, which can in turn cause poor spinal stabilization, which in turn causes, Slade?
Lower back pain.
Lower back pain, exactly. So like I said, you know, what we're really trying to do here, and my goal is to try to take some of the words that you guys are seeing and really tell you why we're looking at it. Not to say, hey, he's got stretch marks. Okay, no, there is a reason that you want to examine that and take it to the next level if you need to. All right, so that's pretty much in terms, I mean, obviously if you see any visible masses, definitely an area that you want to document and certainly we'll be examining further. All right, all the exams that we've done so far, did anybody see anything funky about the abdominal exam? Yeah, so we're, everything that we've done, we've always started with inspection, and then we've moved into percussion, and then palpation, and then auscultation. Percussion sometimes, obviously. But here, we auscultate first. Anybody have any idea why? Why would I auscultate before I start doing any type of physical palpation?
Because palpation can induce like bowel movement and other sounds.
Well, certainly, yeah, absolutely. I actually didn't even think about that. Yeah, it can actually give you a a false read on bowel sounds. What else? Well, look at the structures that I want you to listen to. Why do we ever auscultate certain structures, specifically vascular structures? What do we listen for? What's that term called? Turbinates or brute, right? Abnormal blood flow. So if there is a potential, or potential for an aneurysm or some type of abnormal blood flow, the last thing you want to start doing is start pressing. All right, you want to start pressing down on it. Same thing. If somebody has, poor bowel sounds or they have an obstruction, again, the last thing you want to start doing is pushing down on the abdomen. It's a very bad thing to do. Okay. All right. So we're going to auscultate first. All 4 quadrants. I'm sure you guys have seen the diagram. So we're going to use the umbilicus as our midline, and we're going to use it as our cross mark. So we have all 4 quadrants. All right. Let's just real quick run through. What major structures live in the right upper?
Liver.
Gallbladder. What else?
Liver.
Liver. What about the left upper quadrant?
Stomach.
Spleen, stomach, all right? What about the right lower quadrant? Appendix. Here's a good one. What about the left lower quadrant? Oh, I hope your splenic flexor is not down there. That'd be very bad. That wouldn't be good. Sigmoid colon. Everybody ever heard the term diverticulosis, diverticulitis? Very common in older folks. All right, they're generally going to produce with this, kind of colic. I guess it's colicky pain, but just a sharp, very uncomfortable pain in the, left lower quadrant. Sometimes it wraps around the flank, giving it a, it almost presents itself like a disc condition. I had a guy a couple days ago. Patients that have diverticulosis or diverticulitis, they shouldn't eat nuts. All right, nuts are very bad. Nuts can generally produce it. So this guy just kept getting this, on and off, on and off, on and off pain. The guy was asking, so how much? Oh, I eat a can of nuts a day. That's great. So what happened? Well, we got him off the peanuts and the almonds and all the cashews. He's been off them for 2 weeks. Yeah, I think we got this pain under control. I haven't had it, in 2 weeks. I'm like, I look like a genius. So that's always a good thing, right? It's a joke. You guys can laugh. I understand it's Tuesday, towards the end of the semester. All right, laugh. Hey, listen, we're all having a good time. All right. All right. So the first thing we're going to do is and you can see here, I delineated what is diaphragm, what is bell. I cannot stress this enough. This is a board thing, and it's also it's good medicine. You want to listen in each quadrant for 15 seconds. If you get this on the practical, you bet your butt, her and I will count. Why? Well, because you got to count for vowel sounds. Okay? So you do 1, 1,000, 2, 1,000, up to 15 in all 4 quadrants. Okay? You should hear roughly anywhere between 5 and 34 vowel sounds in that minute. Now, what happens if you don't hear a vowel sound in one quadrant? That's okay, as long as, again, that's why we total them, because, again, vowel sounds, they generally do travel. But you should at least hear at least 1 vowel sound per quadrant. Now, what happens if you don't hear any sound? All right? And this is, again, it's an old school physical medicine technique, but hey, it is what it is. You don't have access, unless you have access to ultrasound in your office, great. Most of you don't. So what happens if you don't hear those vowel sounds? Or if you hear like 2 or 3? Well, you have to go to the ileocecal valve. Anybody know where that is? Point to me, where's the ileocecal valve? Okay. Let's start with what quadrant is it in?
Lower right.
Lower right, exactly, right? The ileum and the cecum meet. Literally, you take your stethoscope and you're going to listen for 5 minutes. I know it sounds crazy, but it's an old school physical exam technique. What happens after 5 minutes? You still hear no sound. Go see a gastroenterologist. Don't worry about it. Let me try to adjust it. Big problem, little problem. What do you guys think?
Refer to the gastroenterologist.
Okay? Do we agree with him? Because he was the first to answer? So what would cause no bowel sounds?
A blockage.
What's that?
A blockage.
A blockage, obstruction. It's a medical emergency. Obstructions are medical emergencies. They warrant ER referrals.
Oh.
Okay? Blockages can, the patients can get sick very, very, very quickly. Okay? You guys will certainly learn more about that, as you continue, with our courses, internal medicine and then pathology. So, but that's the test you do, because unless you have ultrasound or whatnot, it's really going to be difficult. In 6th semester, you'll learn about abdominal X-ray, and unless you're doing a barium swallow, which again, you're probably not going to be doing in your practice. This is the technique that you would be using. Now, it's not common, so I don't want you to think that every single person with back pain, half of them are going to have some type of blockage, but it does happen. All right, elderly patients definitely want to be very, very concerned of, especially if they're constipated, if they tell you they haven't been going to the bathroom for for a couple of days, they're complaining of this deep back pain that's not really going away. Again, it's trying to build a case. Okay. All right, so we listened to all 4 quadrants with our diaphragm. Then I'm going to flip it over, and I'm going to listen in the bell for our renal arteries, okay, and along the lines of the abdominal aorta. Okay? And again, I'm listening for bruits. I'm listening for turbulence, any abnormal blood flow. I shouldn't really hear it, okay? Now, in terms of the iliac and femoral arteries, if you're concerned that there is some type of arterial disease, go ahead and do it. The iliac artery is relatively easy to access here. Obviously, the femoral, not so much, so if you have to do it, you have to do it. But it's one of those, again, you're going to use your clinical judgment. Do you really suspect any type of, arterial disease that, warrants listening to this, okay? All right, so does anybody have any questions on the inspection part and the auscultation part? Relatively straightforward so far, right? Good. Now, in orthopedics, have you guys learned Beaver sign?
Beaver.
Beaver?
Yes.
With the umbilicus? The umbilicus, I should say? Okay. Does anybody remember what Beaver sign is? They call it Beaver.
You do a sit-up basically, and you watch to see if the deviates.
Exactly. This is something really good to check in any kind of spinal cord pathology. The umbilicus should actually just maintain its position. So if he raises his legs, his umbilicus generally doesn't move anywhere. And then at least I know all 4 quadrants of his abdominal muscles are being activated. Very, unlikely that there's a spinal cord lesion at that level. Okay. If you start to see the umbilicus transverse upwards, that's a problem. Usually indicates some type of a spinal cord lesion below T10, because it's knocking out all the abdominal musculature below the level of the umbilicus. All right. So certainly, again, Beaver sign, be on the lookout for that. All right. So now we've done inspection, we've done auscultation, pardon me. Now let's go to percussion. All right. 2 stages of percussion. You have a general percussion and then organ-specific percussion. The general percussion is very easy. Use the umbilicus as your center point, okay? And everybody knows their percussive technique. We've seen it, it looks pretty decent. All right? Now you just make small concentric circles, and each time you make 1 revolution of the umbilicus, you go a little bit wider. Now it should be relatively, you should hear tympany. You're going to hear pockets of gas here and there. So you're going to hear some areas of dullness. Really what you're looking for is are any large, areas or large patches of dullness. So let's say if there was a lot of dullness in this area, I may be a little bit concerned. But if there's a little patch here, a little patch there, a little patch here, again, gas does travel, so I'm not really that concerned. So that is your general percussion. Now, we're also going to percuss the liver and the spleen. But you didn't think we could do that. Pretty cool, right? What do you think, Amanda? Pretty awesome. Come on, right? All right. So, again, the liver, hopefully everybody knows, it's on the right. Again, that was a joke. Man, you guys are tough today. What happened? No one had their coffee today? All right, so we're going to use the midclavicular line. Okay, again, the midclavicular line strikes back again, except this time we're going to be on the right. So find his midclavicular line, and I basically want to find his second intercostal space. All right, now, female patients or patients with large breasted tissue, you really, they may be a little bit more challenging. So if you have to start at the third or fourth, you do what you got to do. But obviously the patient can then lift the breast tissue up and out of the way. Okay. So what I want to do is I want to start resonant. Resonant. And again, try to be skin on skin as best as possible. So I say right around there. Anybody, I mean, again, it's difficult to hear, but you'll hear it shift from resonant to dullness. Well, what's there? Liver. Okay? Make a mark. Now, they actually, if you're really concerned, they sell China pencils or China markers. They're grease pencils, all right, where you can actually make a mark, and they come right off. But obviously, if you make a mark, you gotta make a mark. You need to know where you're going. So you would make a mark there. Okay? Now, still staying in the midclavicular line, I'd go to the abdomen, and I'd start percussing superior. Right here. So I'd make the mark, and then I'd measure the two. Your range is going to be about 6 to 12 centimeters. Okay? If it's enlarged, what's the clinical term? Hepatomegaly. All right? Then obviously that warrants a whole other further investigation. That will, again, as you continue through the program, you'll start to learn more about. All right? But that's how you can percuss and get an approximate size of the liver. Again, if you have access to diagnostic ultrasound, hey, awesome. And if you're really concerned about it, yeah, it's real easy. But, in most rural practices or any practice that obviously is just starting out, you're not going to have diagnostic imaging capabilities. So, that is how you percuss the liver. Any questions on that? What's the range measurement? 6 to 12, right? Shouldn't be over 12. All right. Next, let's do the spleen percussion. You're going to use the angle of the ribs, all right? What rib connects with the basically the inferior part of the sternum? 7. Exactly. You're going to go along the 7th, the 8th, and the 9th intercostal spaces. All right? You're going to start roughly parasternal, and you start doing your percussion. And really, it should be resonant all the way to the mid-axillary line. Once you pass the mid-axillary line, that's fine. If it dulls, it dulls. But it should be resonant really at the mid-axillary line. If you hear any resonance anterior, okay, to the mid-axillary line, could indicate some type of splenomegaly. Not always, but again, definitely something that you want to, document, make a note of, and if there's other suspicion, then, get the patient worked up for it. So you would do that for the 7th, 8th, and 9th intercostal spaces. This thing here, the splenic percussion test, here's how this is done. So you want to find your 9th intercostal space. All right, I have my mid-axillary line. I'm just going to go slightly anterior, slightly. I'm going to start percussing. All right, take a deep breath in. Exhale. The sound shouldn't change. It should be relatively resonant the entire way through. Okay? Want me to show that again, or pretty straightforward, okay? So that's the splenic percussion test. Okay, great. So that's it. So now we have done inspection, we've done auscultation, and we've done percussion. Any questions on any of those three so far? All right, well, let's finish up. Next is palpation. And again, just like percussion, we have general and we also have organ specific. So this time we have two generals. We have a light and a deep. Light, very simple, okay? Again, your hands, you're gonna find your comfortable position. I like to generally go in around a 45-degree angle using my fingertips, and I'm just kind of very gently making small little concentric circles, very light, okay? Make your first pass. Then we're gonna go to deep. I'm gonna go a little bit deeper. Look where my eyes are, I'm looking at him. Problem is, a lot of people, they'll be so focused here. Does that hurt? No, doesn't hurt. And the patient's like this. No, doesn't hurt. Again, especially younger folks, they're not going to be so quick to admit pain. So that's why you always want to have, just out of the corner of your eye, out of your peripheral vision, just look at the patient's face. You've got to look for signs of grimacing. All right, it's something that we're really going to, workshop hard when you take my ER class. So again, you're going to do these nice concentric circles. Now let's say we feel a mass. We feel something. It doesn't really have a nice rebound. It feels hard. It feels, something's there. We need to determine two things. Is this intra-abdominal or is this intramuscular? So let's say I feel a mass right here. All right, so what I'm going to do is I'm going to apply a little bit of pressure there. I'm going to have him lift his legs. It's going to help contract the abdomen. Lift both of them for me. Good, relax them. Now, if this is an intra-abdominal lesion, meaning it's inside the abdominal cavity, when he contracts his muscles, what do you guys think is going to happen? Is the mass going to disappear, or is it going to become more prominent? It's going to disappear, right? Because we have more of an increased tone of the abdominal musculature. Contrary, if it's a lesion within the actual abdomen itself, it'll become more prominent. Okay, so that's kind of a quick little way that you can differentiate intra-abdominal versus intramuscular. And a lot of patients, if they've had any kind of abdominal injury, again, they can have excessive scar tissue formation, which again goes back to that whole abdominal dyskinesia. So sometimes you may feel what appears to be a mass, but it's actually a bunch of fibrotic tissue within the abdomen because of any kind of an injury. Okay? All right, so we've done our general, we've done our deep. We've now managed to differentiate between intra-abdominal and intramuscular masses. Now let's go into our organ specific, okay? And there's 3 organs that we want to palpate. The liver, we're going to be able to palpate the inferior lobe. The spleen and the kidneys, we should not be able to feel. So first the liver. Liver's on the right side, right? That's right, man. That's a tough day today. All right. So I want to take my, my left hand, and I'm just going to put it under the inferior part of his rib cage, okay? And you're going to go in with an ulnar surface. So you're going to use your second digit and kind of ulnar, radial surface. And I'm going to have him take a deep breath in and hold it. What that's going to do is it's going to displace the liver inferiorward and allow me to kind of palpate the inferior aspect of it. All right, go ahead and take a deep breath in. Now you don't want to be sitting there for 30 seconds, especially if the person has, poor respiratory function. So, what you're really feeling for, do you feel any nodularity? Does the liver feel hard? All right, that's really what you want to examine. All right, so that's how you palpate the liver. Now the spleen, again, everything can still be done from the right side. So the spleen, I'm going to have you shift more towards me because I can't really reach over there now. So the spleen, I'm going to come over. I'm going to go underneath the left part of the rib cage, and I'm going to take my hand, again, going at this 45-degree angle, right underneath that 7th rib. Have him take a deep breath in, and exhale. Now, obviously, if the spleen is enlarged, what's going to happen? The diaphragm is going to start to displace it inferiorward, and it's going to pop into your hand. That's a problem. You don't want to feel it. All right, so it should have that same nice, again, my doctor term, mushy. All right, so you want to have that nice consistency. If you feel the spleen pop into your hand, that's a problem, probably enlarged. All right, the kidneys, again, take a hand, go underneath the right flank. All right, and what I like to do is, because you just don't want to start pushing down on that because it's a little uncomfortable. So I have the patient take a deep breath in, and as he exhales, so go ahead and exhale, I start to push a little bit. Give it firm pressure. And what I'm really trying to feel is, do I feel the kidney pop out? Okay, and again, same thing can be done on the other side. Left flank, left part of the abdomen, deep breath in, and he exhales, and I give a gentle pressure. And again, I really shouldn't be able to feel anything. All right, so anybody have any questions up until that point? All right, there are a couple of special tests we do for the abdomen that can indicate potential pathology. Boards love to ask these, and so do the OSCEs. So, the first one is the hepatic punch test. All right? Yeah, exactly. All right, so you want to find, again, that 7th rib, and you're obviously going to be superior to that. You take a hand, you take a fist. Yes, it looks hilarious. It is. But it shouldn't produce any pain. Basically, you remember how like the tuning fork test kind of worked? We're trying to induce some type of vibration to see if there's a possibility of a fracture. Well, again, if there's some type of issue in the liver, providing that vibratory wave, it could, reproduce some symptoms. Okay? So hepatic punch test, that's how that works. It's for a liver issue. Murphy's sign is really important. Okay? I'm going to show you how it works first. So again, I'm going to go right underneath that 7th rib. I'm going to come in, take a deep breath in for me, exhale. As he exhales, I push in, okay? And then I'm just going to quickly let him rebound. Now, has anybody ever heard of Murphy's sign before? All right, this is classic, what you'll see ER doctors do. They'll do it for patients with cholecystitis, all right, or an infection of the gallbladder. Again, cholecystitis, like appendicitis, it's a relatively emergent condition. They'll usually operate as soon as they possibly can, until once the anesthesiologist deems that it's safe. So again, if somebody has a lot of abdominal pain, back pain, they have fever, they're testing positive on Murphy's sign, that's again not all right, call your gastroenterologist, they'll see you in a couple weeks, get into the vehicle, and you gotta go to the ER, all right, because you gotta get some testing done, okay? So that's Murphy's sign. All right, the next ones here, obturator, psoas, Rovsing's, cutaneous hyperesthesia. These are all tests for appendicitis, okay? Obturator sign, I know Paul actually had internal, you saw that?
Yeah. It's internal.
Yeah, so this is technically internal rotation of the hip.
Yeah.
You'll see in the notes, it's external rotation of the leg. Technically external rotation of the leg would be this, right? So you want to externally rotate the leg and just give a little bit of internal rotation into the hip. This is also a great test for piriformis syndrome too. But basically, if this reproduces pain in the right lower quadrant, all right, I'm concerned for appendicitis. Questions on that? The next one is the psoas sign. So he's going to put his leg into external rotation. He's going to keep the rest of the thigh straight. Hold this there for me, okay? I'm going to push down. Don't let me push. Again, seeing if I elicit pain in the right lower quadrant. Good indication for appendicitis. Rosvig's. I'm going to take a point in the left lower quadrant, push down deep, and quickly rebound. Again, looking for pain where? Right lower quadrant. Thank you. Exactly.
How's that one work?
What's that?
How's that one work? I don't, like, why do you press on the left and get
It's a good question. Do you have a?
I do not.
I do not either. Yeah.
Okay.
Why don't you, tell you what? Why don't you look up some stuff and then get back to me next week?
You got it.
But no, that's a good point. Yeah, a lot of these things, guys, a lot of these tests, are from like epidemiological data over the years where they're not necessarily is an answer, but they've done reviews on chart after chart after chart after chart, and they basically made an association with pushing here to appendicitis. That's how a lot of these tests work. So they're measures of association. All right, that's the field of epidemiology.
There's something else going on here.
What's that?
I think there's something else going on here too.
Yeah, no, there should be.
No, because it's supposed to be at McBurney's point. So.
Yeah, that's right.
Which is.
Yeah, that's right. So we're gonna let her, while she's looking that up, let me finish these, and then we'll definitely go over that. All right. The cutaneous hyperesthesia test. This one basically, you're gonna take the skin and you're gonna pinch it. I know, very funny, right? And again, kind of like over the right lower quadrant, the left lower quadrant. And again, if the appendix is inflamed, the thought is the surrounding tissues are also going to be very, irritated. So doing the cutaneous hyperesthesia testing can also elicit pain in the right lower quadrant. Yeah?
Which one is like the one I guess that you use most in practice on the highest evidence?
The highest ones, I mean, again, definitely Murphy's sign. I'll do obturators and psoas and rebound tenderness. And then around now, while we're here, the rebound tenderness is for general peritonitis or peritoneal inflammation. That is not specific to any quadrant. You're going to do rebound tenderness in all quadrants. All right, and again, it looks just like this. I push down deep and I quickly rebound. Push down deep, quickly rebound. I want to hit all 4 quadrants, maybe like 2 or 3 spots in each quadrant, because basically I'm checking for any irritation into the peritoneum. Okay? All right, the fluid wave and shifting dullness, this is for abdominal ascites. I want to see, is there any fluid leakage? Is there any fluid in the abdomen? All right, the first one, the fluid wave, take your hand, I just want you to go ahead like this for me and push down deep. Not the most accurate test, but hey, for boards, you got to know it. You take a hand, and it kind of goes here against the right flank. Take 2 fingers, and I'm going to try to induce a fluid wave. Okay? Yeah, that's the test. All right? So that's the fluid wave, again, checking for ascites or any fluid inside the abdomen. Same thing with shifting dullness. And you'll see here, all the tests we've done so far with the patient supine. The last 2, we changed body positions. Okay, go ahead and line this side for me. So he's going to get in the left lateral recumbent position. Okay? Now, what I'm going to do is I'm going to take my percussion. I'm going to go like, you know, maybe 1 point above the umbilicus, another point below the umbilicus. And I'm going to start percussing. Now, if there's no fluid, should the sound remain the same all the way through? Yeah, it should. If there's fluid, where's the fluid going to collect? Let gravity work in your favor, right? So it's going to be more dull as we get closer to the table. Okay? The last one is Murphy's punch. And I'm going to have you sit up and actually swing your legs to me, so that way I can show them. And this, again, you'll see doctors do. I also do this one too. Same principle for the hepatic punch. We do this for kidneys. All right, so you find the flank. Again, I'm not punching him in the kidneys, but trying to induce a decent vibratory wave. That's it in a nutshell, guys. That's how you can do a relatively comprehensive abdominal exam.